Thank you. I'm grateful for the invitation. Today we had a lot of lectures saying that teledermatology was very nice, efficient, good for patients, good for doctors, very sexy, and I will destroy this now. No. I will be critic with some of the things we are doing. And I think that this is very essential, because otherwise it's difficult to understand what happens. And well, I working here. This is a referral center, high technology hospital in the city center in Barcelona, where we receive melanoma patients, skin cancer patients. And indeed, I'm working in melanoma patients since 20 years. So this is one of my major duties in here. And well, we organize melanoma detection and in a network of hospitals. We see we are in Catalonia 7 million people. Just to explain you where we're based, and this is very important. And these are 26 hospitals connected for melanoma care in our region. Of course, in the city center, we have also a population, 3 million people, that need a hospital. And there we have different regions where we attend the patients in there. In our basic model of health, we have population that is attended most of the times by GPs. We don't have direct referral to dermatologists without the GP consultation. So the GP send to us the patients with some skin problems, and this is different from other places in Europe. In some countries, patients can go direct to dermatologists in Austria and some other countries. But this is the situation. And if the dermatologist is seeing something really bad for the patient, melanoma, then the patient is sent to the hospital. This is our basic model. But here we have a problem because, of course, we have a good number of dermatologists in my country. We have more than 2,000 dermatologists. So the density is assumed to be good for the population in Spain. And the problem is that all these patients have access by GPs, and we have a lot of consultations in dermatology that collapse our clinics with no major problems many times. So when something is suspicious, it's sent to us, and then we have to visit the patient. With that, in the end, we have to decide what to do with this. And in melanoma, with the system, I can tell you, we in the last 20 years, we had no very good numbers. This is a prospective study of the patients that we have in the hospital, melanoma patients that we see for treatment. And we ask these patients who was visiting them in the last years, okay? What happened with them since we had the final treatment? And see what happens. In 25% of the cases, they had a consultation, and in less than eight days, the patient was sent to us. But in 50% of the cases, the delay was very significant. It was from 8 days to 126 days, the time. And in 25% of our melanoma patients, the delay was even more. And Barcelona is not a place where we don't have good health. And clearly, when we correlate this with the thickness of the tumor, that is very essential in the prognosis of our patients, we see that this is very correlated. Well, yeah. In melanoma, we have sometimes a delay that is 2 months, and then we have melanomas like this. Somebody saw the tumor, the patient, and sent to us this patient with this time. And sometimes this is crazy. And then how is that possible today? Well, I can tell you that we assessed that if the patient had a consultation with our GPs, the delay was higher. And this is very correlated with the breast lobe thickness. But this is a very simplistic picture of the problem, because indeed we know that these melanomas that when we visit the patient are too thick tumors, maybe years ago were not so easy for the doctors. And look at this lady with this very subtle pigmentation on the finger. But not very much, okay? With this dermoscopy, if you are dermatology and you know about dermoscopy, this is very suspicious of and very early acral lentiginous melanoma, but most of our GPs don't know about that. And this, maybe it's not very thick tumor, or indeed it's not very thick tumor, but this is a parallel ridge pattern we see in dermoscopy, no discussion about. But this lady had these pictures, and 2 years after, this is a melanoma we received, okay? Because somebody considered, okay, let's do self-examination and see you in some time, and the patient was not coming again, these sort of things that may happen. Okay, so melanoma detection is not so easy. And this is one of the cases we have. Of course, this lady is now having metastases, and we have barriers. Okay, we need to understand these barriers. We can try to break these barriers, but sometimes this is not so easy because we have financial barriers, educational barriers, and many others that we understood in the last 20 years in my country. And probably you have to understand that in your own environment in the end. But we can do something to avoid these problems because clearly I'm treating melanomas with, I have 5 confocals in my department, I have 20 the digital dermoscopy devices, I have 30 dermatologists working there. We have treatments with very advanced melanomas that are very much expensive, but we have an important delay in the early diagnosis. In early diagnosis, we have the optimistics saying that, yeah, we have to improve primary prevention, secondary prevention with self-skin examination, access to GPs, dermatologists. We have to use, of course, teledermatology. And for those that have some risk factors, maybe total body examination, and of course, follow-up of high-risk population in very sophisticated centers. But we have also the pessimistics saying, well, guys, in the last 20 years, we changed very, very few things in prognosis in melanoma, and this is true, because we don't change much in habits, we don't change in mortality, and this is true. Yeah, you know, motivation of GPs, dermatologists is not very high in the end. They are tired, they are overloaded, they have waiting lists, they don't have time to undress the patients. This is true. And it's very expensive to do all this. These are the pessimistics. But I think that perfection, so here you have the optimistics and the pessimistics. But I can tell you, I'm the optimistic one, okay? I'm the optimistic, because we can do many things to improve what we have. And you know Salvador Dalí, he was crazy, but he was very clever. And perfection, okay, it's not existing. So you have to try to improve the things with what you have. And because of that, we try to understand what happened with the GPs. How were they able to detect early melanoma? And because of that, we evaluated the GPs in a prospective study. Now the mice, you know, in the lab we use mice. The mice were the GPs in here. So we randomized 50 GPs in Barcelona and 50 in Naples, in Italy, in a prospective trial. We trained these people to detect a skin cancer with a formal training, with a recognition of a skin cancer with dermoscopy, very basic dermoscopy. And then we told them, okay, half of you will have a dermatoscope and the others not. And you have to visit your patients. And if you see something that is a suspicious tumor, you have to say, suspicious tumor, and we will visit all these patients in our dermatology department. This is crazy. Wow. It was 3,000 patients visited with this design, and you see these are the results. And this is very, very relevant because indeed, when you see the sensitivity and the specificity we have with clinical recognition in the hands of GPs for suspicious tumors, we see that they have not very good accuracy. They don't have the tools to recognize suspicious tumors without any tool like a dermatoscope. But with a dermatoscope, we improved 25% the sensitivity. So this is very relevant in skin cancer detection. A first message is that, okay, we need to teach GPs everywhere, because without this training, it's very difficult for them to select the lesions that are suspicious. And we are saying, okay, telederm is useful for skin cancer detection, but somebody has to choose the lesion to send, okay? And without tools like these ones, it's very, very difficult. Now our GPs are able to recognize this tumor as a suspicious lesion because it's just an asymmetric tumor with some blue. And we teach them that this is a suspicious lesion. It's an early melanoma. Without this teaching, it's impossible that these people will send to you a picture in telederm. Yeah. So, and this lady, okay, this is not very suspicious. Maybe for dermatologists it's a suspicious ugly lesion, but for many GPs it's not, I can tell you. Now my GPs are able to say, oh, this is ugly lesion, I will take a picture and send that to you. This is a fast-growing melanoma, nodular type, that if you have a delay in 3 months, it will be a disaster for the patient. And this is because you can train. But you don't have to train in the usual common phases of the skin cancer. We have to teach them in special sites. But this is very difficult. No, you can teach them. And in acral lesions, in lesions on the nails, many phases of the skin cancer that are not usually recognized by GPs. And about Sandro, this is for you. You were discussing about you have to undress every patient. You know, in this study, we collected a good number of patients that were coming to dermatologists because of hair loss, of some other problems, but not for consultation of a skin tumor. And all these patients were having whole body examination, okay? And then with this, we understood how many of them had an occult cancer. And yet, these are the numbers. This is amazing. 1 out of 47 patients had an occult skin cancer, and 1 out of 400 had a melanoma in this study. And this was not a selected, of course, they were dermatological clinics, but they were not skin cancer clinics, okay? It means that there is a lot of occult skin cancer. So the problem is that, one, we cannot take care of all this every day because there is no money. They told us there is no money for that. Well, it's true that this is time and cost, but maybe we can do better. And this was our concern. Okay, can we advise our GPs to detect risk factors to undress or to have whole body examination? Yes, because we know that depending on the age, easy things like skin photo damage, and this is very easy, you don't have to do whole body examination. History of skin cancer and others, and also the number of nevi they have, you will detect a high-risk population for skin cancer. And maybe this is a key information that you have to take into account. And the total number of nevi that the patient has is correlated with the number of nevi in the arms, and this has been proven in several papers. So if you have a lady that is showing the arm and she has plenty of nevi, you know that she may have a high risk for melanoma. So it's very easy, and this is not taking more than 5 seconds, okay? But what I'm willing to say is that we need to understand that teledermatology in skin cancer detection has to be in addition of all these concepts. Otherwise, it's very difficult. And if you have a patient with all this sun damage, of course, this is a high-risk patient for having an occult cancer on the back. These patients should have a whole body examination as well. Well, we have trained our GPs in all these concepts since 10 years, and we incorporate pattern recognition to detect suspicious lesions, but also we train them to recognize different phases of the skin cancer and also risk factors to detect population of risk. Because we think that they are basic a part of all this early diagnosis effort. And we think that teledermatology, it's working and you can measure many things. And we heard today many of these successful programs. But in the end, it's true that, yeah, if they are not able to select the lesion that should be submitted in telederm, they are not able to detect where are the patients with higher risk for skin cancer to have whole body examination. And they are not able to manage all this. In addition to teledermatology, we will fail. And this is what they are sending. Sometimes this is a dermal nevus, of course. And you have to understand that the limits for the recognition of this as a suspicious lesion or just a banal lesion, it's in the hands of an expert. You cannot teach a GP to be working and recognizing this tumor. This is something that is sent to us as suspicious lesion, and we recognize that this is a dermal nevus. But they are able to recognize things as this flat pigmented lesion, and they send pictures of this. This is a pigmented AK. They don't have to know about that, but they detect this lesion. They are able to select these lesions, and this is very clear, and they send this saying this is possibly a BCC or maybe a melanoma. It's right. They send things like this one because we train them to send this sort of pictures, but then if this is a young patient with this mole, it's not a problem, but this is our duty. They send ZKs, and we will have a number of ZKs that are not easy, okay? Because, yeah, it's a very typical ZK for me, but it's bluish, it's not so regular. I like that they send this sort of images to me. They send BCCs, and sometimes they send pictures like this one saying, I think it's maybe vascular lesion, but look, I think it's a basal cell carcinoma. And they send that to us. It's wrong. This is not a BCC. This is a melanoma. Huh? But it's no problem. So we need to understand how to run telederm in the hands of all this workflow in the future, having a very motivated people working on that. I'm the optimistic, so I think that we have a lot to improve in the future, but we need to understand that telederm is just a tool. Without teaching, without training, and with all this together, it's not working. And with that, I will finish my presentation. Thank you.